One of the beauties of endovascular treatment of CCSVI is the ability to perform this procedure in an ambulatory setting, thus diminishing the cost of the procedure. Yet integrating CCSVI into an ambulatory practice is no mean feat and requires a great deal of detail and thought. Our next speaker is my partner at American Access, Kevin Sullivan, who is going to speak to us on integrating CCSVI into a busy ambulatory practice. Kevin?
Thanks, Sal. Well, this is going to be mainly aimed at people who are just starting out. I assume if you've already doing CCSVI procedures, you've gone through a lot of this already. First, I'd like to talk a little bit about credentialing and privileges. If you're in a freestanding center, this may not be an issue, but if you're getting your privileges or credentials from a hospital, it may certainly be so. Many capable, well-respected interventional radiologists have actually been prevented from doing these procedures. Here's a quote from the dean of the medical school at Stanford. That was actually in the Wall Street Journal in March 2010. It was decided there would be no further procedures. If you're in a freestanding center, you're not dealing with a hospital credentialing committee, you're still not necessarily home free. You will still have to deal with some other issues. For example, neurologists, biologists in your community are going to be probably opposed to this. They're going to take the position on your left here that these procedures should only be performed as part of a trial, and that the procedure should only move beyond this when there's conclusive evidence. They're likely to take the position that that evidence just doesn't exist yet. On the other hand, patients who are sick and want help are going to come to you, and they're going to take very different views. They're going to basically take the position that the opposition that's voiced on the other side is due to influence by drug company profits and money, and neurologist income and control over patients. They're going to basically tell you the decision is theirs. They're convinced that this works. They're likely to tell you that they don't want to wait for trials, which could take years. And that was sort of, I think, crystallized and summarized very nicely by a 78-year-old patient who came to me when I said, you canuld wait for trials, but we're still learning about this. And he kind of shot back, wait for what? By the time you work this all out, I'll be dead. I can't wait. And you, as an interventional person, are going to have to kind of try to bridge these two opposing views. You should also be aware that there's a whole group, or many groups of people out there who are very much opposed to this procedure. They voice these online. Here's an example where when the Canadian Minister of Health announced that they would support trials online was this kind of very negative comment directed at both scientists and politicians. Sometimes these messages get even much more personal and much more negative than this, and if you get involved in these cases and treating these patients, you may be the target of this as well. So you should just be aware that this is going on. I think one of the ways you can sort of try to address these two opposing views that I showed you between the neurology community and some of the patients is when you do informed consent, you have to give a very balanced perspective to the patient. You really need to take the time to answer their questions in detail, let them know what we know and don't know. Some patients will come, in fact, many will come with long lists, and you have to take time to answer those in great detail. And even if they don't come with those lists, you really need to be prepared to give them a very balanced view of what we're doing here. Be careful not to promise more than we can deliver. I think right now we're not very good at predicting who will respond and don't respond to this, so you need to let them know that. They need to be aware of that. I think you need to also tell patients we're in the early stages. We're still learning. We're still trying to understand this procedure, and they should know that before they get treated. Certainly, if possible, it's good to add to knowledge. If there's an opportunity to become part of a registry, I think that's certainly something that's worthwhile. We just lost one of our screens here again. You should also be aware that there is a learning curve. If you're performing interventional procedures and you have the skills to do this, you probably can do these CCSVI procedures, but you should be aware that there is a lot to learn specific to CCSVI. In particular, you need to learn how to diagnose the disease. I would encourage you to have patients get some sort of non-invasive diagnostic studies prior to the procedure. I know there's some discussion of bringing patients right to venography. I would encourage getting ultrasound using the Zamboni criteria or MR prior to this. You need to learn in detail about the symptoms of CCSVI. Certainly, if you're going to assess whether you've had a good result, you need to know that. You need to know the angiographic findings in order to direct your therapy, and also know something about complication prevention and management and how to follow up these patients. I think it's apparent from the talk today, this is a very much evolving field. It's good to keep abreast of what's going on in this field by meetings such as this. Certainly if you can find a mentor who's doing these in large volumes that you can bounce ideas off of, that's certainly a good idea. The internet can also be a good source of information, both to understand what patients are thinking and also physicians that are involved in these internet sites, and you can learn from some very experienced physicians on these sites. You're also going to be asked how to integrate CCSVI into ongoing procedures. Some patients come under the care of a neurologist, others not. And you'll have to decide how to interact with the neurologist that the patients may be being cared for. I generally tell patients that's sort of up to them. I don't want to become between them and a neurologist that they like, that is helping them. Most of the patients, frankly, say that they're not going to tell their neurologist, that neurologists don't want this procedure done, and that they're going to tell a neurologist after they get treated. But that's really up to the patient. Many of these patients will be on disease-modifying drugs. They'll ask you, should they stop them, should they continue them, and also many of them are on alternative therapies. I generally tell patients at this point we don't really know if any of these medications affect the outcome of CCSVI procedures, so I usually, again, I kind of leave that up to the patient and their neurologist. Coding and billing. Up until recently, it was possible to get paid by insurance companies for these procedures pretty much uniformly. Just recently, Blue Cross Blue Shield in the states that I've listed here have stated that CCSVI is not considered medically necessary to be treated in patients with CCSVI. So if you, and what's important here is the state the patient lives in, not the state you're practicing in. So if you have patients coming with Blue Cross Blue Shield, you will need to check on this. And you can look at the website. Since we're in New York, I put Empire Blue's website here, but obviously you can look at any of these others as well online to see what their policies are in detail. You'll have to decide how to deal with rejections. I suspect in those states you're not going to have much luck getting the rejections overturned. We do have some patients that we treated who had Blue Cross Blue Shield before they made this policy, so we are trying to appeal for those patients. If you're just starting, that won't be an issue. It is for us, and we'll see. I'm not sure where that's going to go. We're just starting to do that now. You'll have to decide if you do want to appeal, do you want to give the patient the codes and have them do the appeal, or to have your office do the appeal? You also will need to determine how you want to charge patients cash if either they don't have insurance or their insurance rejects the procedure, rejects the coverage. And that's something that you should do in detail with your office staff so that they know what to do when the patient comes. You can, for example, there's different ways of doing this. Some interventionists will charge one price for a venogram, another for angioplasty, another if they do stents. That's one approach. The other is to simply charge based on where you put your catheters and what interventions you perform. But whatever it is, you ought to think about this in advance and have it all worked out with your office staff so they're prepared to deal with this when a patient comes and wants to pay cash. This is a billing sheet. It's kind of hard to see here. I'll go over some of the CPT codes. The ICD-9 code, if I can read it from it's kind of small here, but I think it's 437.1. It's general cerebrovascular ischemic disease is the ICD-9 code that we use. And the billing codes really are not specific for CCSVI. They are basically venogram codes. They're the radiology SNI and catheter placement codes for venography and angioplasty and stenting. There's nothing specific about these codes. And you should be aware if you submit these codes, generally insurance companies will say they don't require pre-certification, but you ought to be careful if you have a patient with Blue Cross Blue Shield where they specifically have said that they're not going to cover it, because my billing and coding people tell me if I do that, if I submit it and they order the chart, we will probably be required to give the money back to Blue Cross Blue Shield. So you need to be a little bit careful about that. In terms of building a practice, you should understand you probably will not get referrals from neurologists. I do get some, but not many. You can get involved in some of these online sites that I mentioned earlier, and many of them you can join as a physician, and you can answer questions, and becomes known to patients that you're interested, willing, knowledgeable, and that's one way of starting to get patients. You can establish an online, or rather a diagnostic component to your practice. If you do that, if you have a vascular tech, I would urge you to send them someplace to get trained properly to do this. And also direct patient marketing is also an option. In terms of the workflow of the patients through your office, it's important to basically review the diagnostic criteria. As I mentioned earlier, I really would urge you to send patients, if they don't come with it, with a non-invasive diagnostic imaging study prior to them coming to you, or order one and have them come back if they see you first. You need to do a careful review of the signs and symptoms. Again, like what I mentioned earlier, you really have to learn about the signs and symptoms of CCSVI/MS so that you can make an assessment as to whether you've been successful after the procedure. Leave enough time to obtain a good history. Answer all the patient's questions, discuss treatment options if that's relevant. I would say at least 30 minutes and as much as 60 minutes to do that. Some other things you'll need to decide. Determine if you want to treat patients who have CCSVI without MS. You will see those. Also determine whether you're prepared to treat children. I think it's one thing in a hospital setting, we have a lot of other specialties, but if you're in an outpatient center, you need to decide whether you can handle the complications and problems that might develop if you treat children. In terms of the procedure itself, you should probably figure on leaving about 2.5 hours when you first start. I recover patients for 4 hours. Now, in my practice, I give everybody full anticoagulation during the procedure. I take the sheath out immediately afterwards. But as long as I keep the patient supine for 4 hours, I have no problems with hematomas. A few ecchymoses if patients move, but no hematomas. Of course, you got to make sure you have enough nursing personnel and space to do the recovery. One good thing is these patients have essentially no pain post-procedure, so there's very little need for nursing and to take care of pain problems. Equipment, I think probably the biggest change probably from current practice is when we got into this is we had to have a full line of balloons that were 120 centimeters long, diagnostic catheters, a full line of catheters, 90 centimeters, and exchange length guide wires. In many patients, you'll be able to get there with 75 centimeter balloons and 65 centimeter catheters, but not all. And so you need to be prepared to have to treat taller patients. Follow up, when I first started this, I thought I'd get everybody back a month, 3 months, 6 months, a year. What became apparent pretty quickly is these patients many times travel long distances, and travel was difficult for them, so I kind of abandoned that pretty quickly. We do telephone follow-up with these patients. I also encourage my patients, I give them my email, I encourage them to email me questions and also with changes in neurologic status. And when they do that, I put those exchanges in the chart so I can keep a record of it. For my patients who may see this online, if you haven't sent me an email, please do. It's really how we learn how they're doing. And then if they have a problem, then I bring them back for a follow-up ultrasound usually and examination by me. I guess in an ideal world, I like to get patients routine follow-up with ultrasound using the Zamboni criteria. I don't know exactly what that interval should be. I probably would start off with a month, 3 months, 6 months, and a year. The problem I have with it is it's hard to find, particularly when patients are coming from a distance, it's hard to find places to send them that can do ultrasound properly. And I'm in Atlanta. We have a very good group there. CCSVI Atlanta does very good work. So locally, I can get good ultrasound, but I can't get that everywhere right now. MRV is also an option. I don't have a lot of experience with that, but that would be another way of following up patients. I'm not going to get into anticoagulation protocols today. I think probably that will be covered when people discuss, other speakers discuss angioplasty. Just in terms of practice workflow, I think one thing you should realize is that if you want to put people on Lovenox, some pharmacies will not have enough supply to if you write a prescription for several weeks, so you may want to call ahead, get the patient's pharmacy. Or another problem too is some patients, if they fly, are very concerned about flying home with all the liquids. My understanding is if it's labeled as a prescription, they should have no problem, but patients are still concerned. And so what I've started to do, and a lot of people, is they have these pharmacy services where you can actually get, this is the paperwork from one of them, you can get their paperwork, write a prescription on it, have your office staff fill out the patient's name, their insurance information, fax this to the company. They'll take care of if they'll bill the patient's insurance, they'll charge the patient a copay, and they'll actually ship the Lovenox overnight to the patient's home, so it eliminates all those problems that I mentioned earlier. And patients generally appreciate this. So this is something I've done when I want to put somebody on Lovenox. So in conclusion, you probably have the necessary skills if you're performing other percutaneous procedures. Although you do need to learn some details about CCSVI, such as meetings like this. It's important to understand that the political environment and insurance policies may be barriers to you doing these procedures. And also you need to be comfortable with some of the controversies that will surround CCSVI. Thanks.